started. So thank you everyone for joining us today to our webinar, Protecting Patients from Medical Debt, Strategies for Hospitals and Health Systems. We have a really great discussion planned for you today with our panelists. I'll introduce myself. My name is Uzma Amin. I'm a manager at the Healthcare Solutions team at Financial Health Network, and I'll be serving as the moderator today for our discussion. I'm joined by one of my colleagues here at Financial Health Network, Michelle Proser, who is the Senior Director. She will be monitoring the chat, so please feel free to use that chat function, as I mentioned before, with any questions that come up throughout the webinar. And again, for anyone who's just coming in, there's a closed captioning feature at the bottom if you would like that. All right, great. So a quick look at how we'll be spending the next hour. I'll be kicking us off today with a brief intro to financial health, how it intersects with healthcare, highlighting how medical debt is an example of how healthcare can disrupt financial health, and then share some findings from the medical debt report series we recently published. Then we'll have our facilitated Q&A with our panelists, and then open up to Q&A with the audience. So for those of you who may be unfamiliar, the Financial Health Network is a national nonprofit with a mission of improving financial health for all. So we work with system level actors to affect change for the financially underserved. And we have a history of working traditionally with financial institutions, but now, increasingly working with employers and healthcare organizations as well. So what is financial health? You may have heard from other organizations, things like financial wellness, financial strain. We use the word financial health. So at Financial Health Network, we define financial health as a person's ability to spend, save, borrow, and plan. And we believe that financial health is something that comes about when the systems around you help build resilience, and pursue opportunities over time. So these can be financial systems, of course, like financial institutions such as banks, credit unions, things like that, but they can also be your employer, right? And they can also be your hospital's billing department. So we aim to look at a totality of an individual's financial life to ensure that they're able to spend, save, borrow, and plan. And this allows us to calculate a FinHealth score. This score can then help us understand if an individual is financially healthy, financially coping, or financially vulnerable. We have a short survey with some questions along these 4 buckets that allows us to calculate this score. And this is a validated framework that has been adopted by many organizations as a way to improve financial health for those they serve. All right. So as I mentioned, our framework is holistic, and we tried to go beyond just looking at income. We found that income alone does not determine a person's financial health. In fact, 17% of those with incomes less than 60K are actually financially healthy. And on the other hand, we found that 40% of those with incomes greater than 100K can actually be considered financially coping or financially vulnerable. So we know that there are other factors at play that determine a person's financial health. So we've known that health and financial health are intertwined, and the pandemic has only further highlighted this. So economic security enables an individual to better access the conditions that facilitate good physical and mental health. And so financial health can be considered a key social determinant of health. And on the other hand, healthcare decision-making and utilization of healthcare services can impact a person's financial health. Medical debt is an example of this, right? Someone can interact with the health system, get care, right? And then get a bill that they can't pay, and then have their health and financial health disrupted. Oh, sorry, skipping slides. All right, so we've found that medical bills and costs can affect mental health and physical health. So So much so that patients who are concerned about the cost of their care are more concerned about the cost of their care than their care itself. And some may even delay or skip treatment or medication because of the cost. Oops. And the struggle to pay medical bills can also disrupt financial health, and families are forced to dip into their savings or make critical trade-offs when paying for other needs in order to pay their medical bills. And so when we're talking about medical bills, what are we talking about? In our research, we found that the typical amounts of medical debt were somewhere between $400 to $800. And this may seem relatively small, but if we contrast this with the finding that more than 1/3 of Americans would be unable to cover a $400 unexpected expense, we can see that even an amount of $400 can be burdensome enough to tip somebody from being, financially healthy to financially coping to perhaps even financially vulnerable, and bring a family financial distress. So who has medical debt? We've seen in our research that medical debt affects 1 out of 5 Americans, but the burden of medical debt and the financial challenges it brings is disproportionately large for some groups. And this includes people of color, people with disabilities, people living below the poverty line, and people who are underinsured. And just briefly, I want to mention on the point about the underinsured, we found that insurance does not always protect against the cost of medical care. We've seen with things like high deductible health plans, really high out-of-pocket costs, and we think it's important to include both the uninsured and the underinsured in actions to prevent medical debt. All right, so now we'll launch into our discussion for today. We have 3 wonderful panelists for you who have helped us develop our series on medical debt. I'll introduce them briefly, and Michelle will be putting their bios in the chat if you'd like to learn more. So today we have Sarah Coombs, who is the Director for Health System Transformation at the National Partnership for Women and Families. We have Richard Gundling, Senior Vice President at the Healthcare Financial Management Association, and we have Pat Merryweather-Arges, Executive Director at Project Patient Care. So they're on camera here for you to see, and they will be engaging in our Q&A today. And once again, my name is Uzma, I'm the moderator, and I'm with Financial Health Network. So really briefly, this report series that I have been mentioning, it is a series that we've developed with support with the Robert Wood Johnson Foundation over the last 1.5 years, focused on identifying actionable strategies that healthcare actors can take to prevent medical debt. And we started off, with some literature review, some desk research, and then did a series of convenings and interviews with the Stakeholder Advisory Council that was made up of hospital reps, insurers, employers, patient advocates, some tech vendors. And through our discussions with them, we were able to hone in on what are the true drivers of medical debt and ideate on what opportunities there are for system actors to take action. And medical debt is really a cross-sector issue, as you may imagine. And with the Advisory Council, we focused on 3 stakeholders that we believe can make an impact on medical debt. So hospitals and health systems, insurers and employers, especially for commercially insured patients, as I've mentioned. We did not choose to focus fully upstream on the policy drivers of medical debt. Of course, that is important, but we also still wanted to focus on strategies that were preventative rather than just mitigating. So we fell somewhere midstream in this area that is highlighted here on the screen for our target areas. And our discussion today will focus specifically on actions hospitals and health systems can take, while I've also mentioned insurers and employers as other key actors that we'd like to focus on. And our strategies fall into 3 main buckets that our panelists will discuss shortly. So improving financial assistance and repayment programs, supporting informed patient decision-making, and proactively identifying risk of medical debt. All right, so now I'll cut the slides and bring us to our panelists. So if our panelists can all be on camera, hello everyone. All right, so to kick us off, we've talked a little bit already about why preventing medical debt is important for patients and families. But can you all talk a little bit from each of your perspectives and where you sit on what is the value add for hospitals and health systems when they make these changes to prevent medical debt? What do they gain? So let's start with Sarah, and then we'll go to the others.
Sure. Thank you, Uzma, and folks from the Financial Health Network for having me join this conversation. As Uzma mentioned, I'm from the National Partnership for Women and Families, and we are a policymaking advocacy organization based in DC. And for more than 50 years, we've stood at the forefront of fighting to advance healthcare and civil rights and economic justice for women in America. So I like to think about this work through the lens of women, and particularly women of color. Healthcare organizations right now are really increasingly thinking about how to make health equity a strategic priority, albeit with varying degrees of intentionality or success. And as part of on another ongoing Robert Wood Johnson Foundation project that we will be launched this summer called Raising the Bar, we conducted consumer-focused interviews and held many roundtable discussions to understand how healthcare systems should embrace all of their levers and resources and opportunities at their disposal to advance equity and excellence. And what we heard is that one of the ways that healthcare organizations can make good on their promise of advancing health equity is by addressing medical debt. Because as Uzma mentioned, health and economic well-being are inextricably linked. Medical debt disproportionately affects people of color, women, people living with disabilities or complex health needs, and people living in rural areas. And when you think about Black and Hispanic women, and as well as transgender and gender nonconforming individuals, they are particularly at risk for medical debt due to centuries of systemic racism and sexism and discriminatory policies that have not only contributed to racial health inequities, but also contributes to the disproportionate impact that medical debt has had on communities of color. So, I think when you put that all into the context of the disproportionate rates of medical debt, the disproportionate rates of, racial inequities among certain health conditions and racial and ethnic groups, and the fact that, medical debt also contributes to poor health outcomes, including mental health, and that it exacerbates economic and health inequities, it really just keeps communities of color in a state of poorer health and financial insecurity. So I think the value add for hospitals and health systems in addressing medical debt is really, building trust with communities and showing their commitment by actually putting actions into words and providing or improving that they are actually intentional about improving the health and economic well-being of communities most affected by systemic inequities. And I just want to put a plug in for the National Consumer Law Center and Community Catalyst, who've been doing a lot of impactful advocacy work in lifting up medical debt as a racial justice issue.
Great, thank you for sharing that, Sarah. Yeah, I definitely think that the idea of, medical debt being a way for hospitals to make good on the promises that they've been making over the last couple of years on equity, racial justice, especially as we've seen the pandemic roll out and seen the disproportionate impact on certain communities based on the systemic disenfranchisement that's been happening over centuries. So yeah, thank you for bringing that up. Let's go for Pat.
Thank you. And thank you for inviting us to this important discussion on medical debt. I'm with Project Patient Care, and it's an advocacy and representation organization for patients, residents, families, and caregivers. And it works collaboratively with healthcare providers. The challenge that we have today is that there is a lack of information that is available to consumers in terms of the cost of care. And what consumers have seen is not only that they don't know about the cost of care, they know that the only thing they know is it's rising. And so when you think of the trust factor that goes into a procedure or an episode of care, the patients really do want to know not only about the clinical issues and addressing their concerns or their diagnostic preventive treatment, they also want to know what is the cost of care. And so with that, by providing information to the consumer as they ask for it, and or as the provider provides that to them, it helps in their decision making, so they can decide to get care or delay care. And what oftentimes happens is there's a great perspective that the cost of care is not affordable for many people. Even if they have insurance, the copays that exist right now are high. But having that conversation and knowing if the patient has the ability to make a payment or what types of payment arrangements can be made really goes a long way to build that trust. And right now, I think you'll see that, through the many publications that have occurred over the last couple of months about the price transparency regulations, where providers are supposed to be posting their information, and the findings that many of them are not posting, or they're not easily accessible or readable for the consumer. I think that points to a challenge we have in trying to build that bridge, because cost of care, too high or perceived cost of care, that will prevent consumers from seeking treatment, getting the treatment that they need, as well as doing any type of preventive care. So I really have to say we saw the swell of response to the vaccinations because they were offered free, as well as, again, looking at the cost of care from a patient perspective is really important, because they will make decisions that way. And it's like buying anything. If you went into a car dealer and you wanted to buy a car and they said, well, I'm not going to tell you what it is until you drive it and it's yours, that would be hard to take for most people. It probably wouldn't occur. So I really have to say building that trust is really key, especially on something that's near and dear to them, which, as we just talked about, many patients cannot afford, or even the cost of $400 may be out of their reach. So again, I think there's opportunities there to really start a dialogue with patients on the cost of care, and to do it quickly, because again, I suspect we're going to see many patients that just don't get the care, and it's avoidable hospitalizations and avoidable deaths as well.
Yeah, thank you, Pat. And I love this idea of making the cost of care and care cost discussions part of the patient experience, right? Mm-hmm. And as like a bridge for building trust. I love that. And finally, let's go to Rick.
Hey, I'm Rick Gundling. I'm a Senior Vice President with the Healthcare Financial Management Association. It's a professional membership organization of healthcare professionals, about 83,000 healthcare professionals across all areas of the healthcare system, from hospitals, physician practices, FQHCs, health insurance plans, CMS itself. And we work very collaboratively with all types of, I think, Sarah, you mentioned Community Catalyst. We've worked for years with Community Catalyst as well. Many of our members are actually the ones that are sitting in the admissions office or sitting in the admissions clerk. And they're many times the first dialogue that a patient will have about what their out-of-pocket costs are going to be. They might have read about if they're insured, they might have read about their health insurance plan, but no one remembers their healthcare benefit design until it's time to actually do it. And so those are the conversations. And so we've been making many efforts for our members to start having those conversations and to be the ones to initiate it. Because I think I've mentioned before that some of the most awkward conversations that we have are around our health and around our money. And we put it together in healthcare finance. So and patients may be reluctant to have that conversation first. So the hospitals need to, and physician office needs to be the first ones to step out and to talk about that benefit design. And we always say financial harm is real harm, not just on the clinical side, but it's actually harm itself. And that we need to take the mystery out of what the patient share is and what the patient will owe. And it's not a one size fits all, because based on your financial needs, your benefit design, as I mentioned, where you are, that everybody could, many people could have Blue Cross Blue Shield in the state, but the benefit design may change it, and your out-of-pocket costs may change based on that design. And so, I think, Pat, as you were mentioning about the conversation, we truly believe it's the conversation that needs to happen, because even if you had a price list of, on the hospital's website, how your health insurance and its out-of-pocket costs and where you are in your deductible may be vastly different than what shows up on even a transparent price list. So really that building that trust, that conversation needs to happen. And in those conversations, many times a patient may be able to have, the hospital can determine through a financial counselor that they are eligible for financial assistance policy, maybe eligible for charity care policy. So out-of-pocket costs again may change, or they may have coverage that they didn't realize that they were eligible for. Maybe they're eligible for Medicaid. Maybe their workers' comp should be covering that. So that's why it's so important to build trust, have conversation, because it's not a one-size-fits-all. And many times it's not the hospital's the best place for the price on your benefit design. Your health insurance is, and can be able to help navigate you. So again, it's, we have, it's not a one size fits all. And I think the conversation can kind of bring it down to that human level. So.
Yeah, great. Thank you, Rick. And some of the things that you started mentioning about charity care policies and how hospitals can really be at the forefront to step up and, bring that conversation to the forefront is a perfect segue to start talking a little bit about the recommendations that we actually made in the reports. So we talked about this briefly already, but the recommendations that we made in the report for hospitals and health systems and the strategies that they can take sort of fall into three main buckets. One of them is supporting informed patient decision-making, which we've already started talking about with the price transparency. The second is proactively identifying the risk of medical debt. And then the third is to actually improve financial assistance and repayment programs. So I would love for each of you to sort of talk about one of those. Why do you think that bucket is so critical, and any potential challenges there may be for implementation, or any best practices that you've already seen out in the field along those lines? So again, let's start with Sarah. And can you tell us a little bit about any best practices you've seen out in the field with supporting informed patient decision-making, and any challenges that you may foresee with actually implementing some of these strategies?
Sure. Well, I think, as you said, we've already discussed price transparency, and I think it's a really key, important way to help support informed patient decision-making and building trust, to really help patients and caregivers understand their out-of-pocket costs. I think part of the challenge is also thinking about how to provide price transparency tools for that are provider-facing, because price transparency is similarly important for clinicians and other caregivers as it is for patients. And I think oftentimes providers rarely know the price of the services that they're delivering, or the cost that these services cost to patients. But price transparency tools can really provide an opportunity for providers and patients to discuss more affordable care options if high quality alternatives do exist. And it can enable providers to encourage, or price transparency can encourage more effective shared decision-making around treatment options, which has proven to improve patient outcomes and improve both patient and provider experience. But I do think that one of the challenges of improving price transparency tools, or improving access to price transparency tools, is that these efforts should really be making equity an explicit goal. And if equity isn't part of the goal of the design from the very beginning, there's a risk of increasing or exacerbating disparities. And so the tools or information that are provided to patients and caregivers should really be used, should really be usable and available available to all consumers, including people with disabilities, people with reading comprehension impairments, people with specific health literacy or cultural needs, and people with limited English proficiency. It really should be made as easy as possible for consumers to get cost of care information. And these tools and information should be accompanied by information about available financial assistance programs, which I know Pat will get into in a second.
Yeah, perfect. Thank you so much, Sarah. The point that you mentioned about making equity a focus from the beginning, that's really interesting to me. And you've mentioned some of the ways, like reading comprehension level, things like that. Anything else that folks should be thinking about from that equity perspective so that they're embedding it right from the beginning when they're designing these new policies?
Well, absolutely. And I think we might be able to get into this a little bit later, but I think involving patients that are well representative of different racial and ethnic groups and other, systemically marginalized populations into the design and decision-making processes of developing price transparency tools is going to be critical to centering equity.
Perfect. Thank you. And you segued perfectly into what I was going to ask Pat about improving financial assistance and repayment programs. So Pat, I would love to hear your perspective on that. Any best practices you're seeing out in the field in that space and any challenges that you could foresee?
There are many opportunities to improve the financial assistance to patients. And certainly it starts with first having those discussions. Discussions if it's a planned a procedure or service that's being provided, what are the costs involved, and asking the patients, having a discussion about what do they feel that they'll be able to meet those costs, and what is their share of the cost of the care being provided. Now, having said all that, I do want to say that this reminds me of when we were rolling out, and not to compare it to end of life, but end of life issues and starting to have those discussions. We did quite a bit of modeling and role playing to get people used to having those conversations. Talking about finances for many people is a very personal issue, and one that oftentimes they don't want to disclose. And so it's, again, having that trusting conversation, getting clinicians, because that's where the costs are going to be discussed. I know sometimes they're the business office or areas like that, but it's really, if you want to do shared decision-making about options available, it has to be part of the clinician, or at least somebody in the clinician office that can talk to them. So starting to think about role-playing to have those discussions about options available. Oftentimes people will say, I can't afford this. And there may be different types of clinical studies that are going on, or options for different providers or foundations or charitable. We don't track that information. And one of the things I was thinking about as we were discussing this just now was, why are we not putting that on the patient experience surveys? Because again, this would be a great opportunity to know if the patients were provided with information, were they asked, and did they feel comfortable about the discussions going on or the outcomes of the discussion. So I think if we really want to get a great handle on the clinical care, we need to also be addressing this level of care, because patients will not follow through on their care plan if they don't think they can afford it. So I think we have opportunities there to really make a difference. And I do believe that, as was said by Sarah, that we need to have conversations that address the equity issues, because we have people of different languages. You're not going to pick up, I hope you don't have to pick up the phone line to get somebody to communicate and translate. That loses some of the interaction. But again, if that's the only option. But I think having those conversations, being trained in different levels and with different participants, I think is going to be critical. And I can't emphasize enough the role of the clinician in this area. I know they shouldn't be put in the position to have to know all the costs of care being provided, but many have taken it upon themselves. I know one hospital emergency room that gives out a listing to all the patients that come through the ED and are being discharged, if they're being discharged with medications, as to the different resources that are available so that they will take their medication, they will follow through. And many of them are low cost, very low cost options available. So I think by taking a proactive role in providing information and resources, because there is a wealth of resources out there, if care is viewed as being unaffordable for a patient, but you absolutely need to start having these conversations. And it's not just the inpatient side, it's the outpatient. This is where we're seeing a reduction in terms of usage of preventive services, preventive diagnostic services, because they don't believe they can afford it. And because the cost of care has gone up on the outpatient side and more has shifted to the outpatient side. You know, if you're having a knee surgery on the outpatient side, your cost of care is going to be much more expensive for the patient than if it was on the inpatient side. So I really think there's many opportunities to improve the patient experience, enhance the trust between the providers and the patients, and make for, you know, an equitable environment for all.
Great, thank you, Pat. And you mentioned like we've talked about this as well, just having those conversations about money, and, you know, you likened it, you know, somewhat to like the end of life conversations that you were talking about. These are uncomfortable conversations. Like, yes, people may be worried about the quality of care they receive, right? If they disclose their financial situation, right? But that needs to rest on already having that trusting relationship, right, with your provider and with your health system. So yeah, so that, and I think that stems from knowing your patient population, right? And really listening to them. So that's what I'm hearing a lot from all three of you, and that's great. Rick, let's turn to you. Let's hear your perspective. How can we really proactively sort of identify patients that may be financially at risk and better support them?
Absolutely. Well, you know, as I think Pat and Sarah have mentioned it before, you know, we're seeing much more the changes in the healthcare system. We've seen much more out-of-pocket responsibility on the patient. High deductible health plans. You know, we just see, you know, the era of just having a $10 copay, or has changed to a $2,500 copay, and so it's the whole environment for healthcare systems have changed too, and the providers. So they are moving more from and sometimes use the term like a wholesale, where they dealt mainly with Medicaid, Medicare, and insurance, directly with the patient themselves, much more in a retail environment. So that the ability to identify patients that are in need, and it has grown exponentially, and to be able to make sure that patients get navigated to plans and payment options and assistance plan is as imperative to the health system as it is to the patient as well. And so many are more investing in financial navigators, financial advisors, you know, internally, to be able to work directly with the patient. And this isn't just in hospital settings, but in, you know, large physician practices as well, to be able to navigate there's large out-of-pocket expenses that even if somebody's working and has an employer healthcare plan, you know, is responsible for thousands of dollars. And so I think that is key, and to be able to identify those patients that are cannot afford it and are unable to pay, behooves the health system as well, and the physician practices, because if somebody cannot pay, identify them as a charity care or a financial assistance policy much earlier in the process, because it is costly for the health system to do debt collections and as well for a bill that's not going to get paid anyway. And so they're putting much more effort up front to be able to have that conversations. And I think both as Sarah and Pat have mentioned, to be able to have that conversation where you're talking about their treatment plan. And the clinician, even in the exam room, can be able to just to offer it up front. Are you able to afford this? Could you have that, just in a much more, in a very non-judgmental, kind of safe environment to have that conversation. And then if the patient, in that conversation can say, no, I cannot afford it. That's where the clinician can help navigate to the next area to say, okay, well, there are other avenues we can look at. Maybe there's, if you needed I think Pat, you were using an example of a knee surgery. Maybe there's physical therapy at first. Maybe we can wait a few months as you save up for that. I mean, there's just other options that can happen in a very safe environment to be able to look at. And when I've had conversations with patients, I think sometimes clinicians it's awkward for them to have conversations about money too, because they don't want the patient to feel that money is going to get in the way of their care. But patients say, I want to know as soon as possible, because sometimes it's a level, Sarah, I think you were bringing that up too. It's kind of a leveling effect where I may not be able to talk about, different disease patterns, but I can talk about money. And it's kind of an equalizer for me to have that conversation right away. And to be culturally sensitive too about talking about the money and the equity and things like that, I think is really key. And just, as we've seen with the Affordable Care Act, and people have had coverage expansions, but just to even understand the terms in network and out of network makes vastly different pricing decisions for a patient. It makes a big difference. And that's why I think that the price information right away is so important.
Yeah, great. I want to just stop and sort of double click on one of the things that you mentioned, Rick, about all of these recommendations we're talking about. It behooves the healthcare system to do them, right? And I'm seeing some questions come up in the chat as well about hospital financial assistance policy that I want to sort of like have a discussion about since we're already on the topic. So we've seen that, a hospital may give a bill to a patient that they're unable to pay. And then there's this whole like running around, chasing the patient down, having them pay. Is that in the hospital's best interest to be doing that? Could we have identified this patient for financial assistance or charity care, reduced cost of care earlier on, and just like avoided this whole process? So I'd love to hear from all of you on any best practices for financial assistance programs and financial assistance policies. How can we take an equity lens to that? How can we make that better? One of the things that we found in our research is that I think it was 45% of nonprofit hospitals are still sending bills to patients who qualify for charity care. So that is still happening. How can we sort of address that? And how can we make sure that patients are able to know about the financial assistance policy, actually access it, and that we're proactively identifying them. So I'd love to hear from anybody on that. Go ahead, jump in, Pat. Go ahead.
Okay.
Yeah.
I think that, again, the proactive approach certainly is the best approach for both the patient and the provider. I was on the National Uniform Billing Committee for 17 years. And I have to say that during that time, at just about every meeting, the issue over the ability to put together a bill that patients can understand was always discussed. And so we have seen some strides by many healthcare organizations to put together a bill that patients can understand and read. But I also think there needs to be preparation for the patients. Oftentimes, the first time they get a bill is when they get a bill that they don't understand or can't make sense of. And then they don't realize they're going to get bills from different providers as well for their stay. I think the surprise billing, that piece of legislation was very helpful to patients in terms of reducing that amount of surprise billing where you have no idea where this came from because you were seen at this hospital, not by a provider. I think that's really key, and is starting to continue on chipping away at all of the areas that we can improve the process. Because when you get a bill and it's just a notice, but it's not a bill, people think it's a bill. And immediately they get, a few $1,000s, they're shocked. And then there's the negotiation that takes place if there is a health plan involved. I think there's so many levels. And for many people, if they're in an accident or they develop a disease, it may be the first time that they have encountered the healthcare system this way. And yet we give all this information about your stay, the meals, the television, everything like that, but we don't have those discussions about the bills that will arise. And that is also a perfect time to really reach out and ask, are hospitals providing any level of information? Are they knowledgeable, and are the providers knowledgeable, and are they asking if they qualify for charity care or any type of reductions in payments? So I would love to see the answer to that question, because from our perspective, it doesn't happen all the time, and oftentimes it's rarely happening. So again, I think some providers are very good at it, but other providers, it just doesn't enter into the discussions.
Yeah, I'll just dovetail off. Absolutely. Again, it goes back to that conversation and trust. I think somebody who can't afford it or needs the charity care is probably the most reluctant to ask for it or to inquire about it. I was recently in an emergency room, and I did see the signs behind them, ask about charity care, and I looked on their website and they were there. But I think but I think having a person asking about it, and unfortunately, a lot of patients don't bring it up or they don't talk about it. And it's in that debt collection process. The debt collectors many times are the ones that discover they don't have the income for that, or they have those kinds of things. So unfortunately, that's so far along before they should have been identified right away. And it all goes back to conversation, trust. I think the health systems themselves need to reach out to the patients, much more proactively, to have a safe conversation about that, to identify as well. So
Great, thank you. Sarah, anything to add there?
Pat and Rick raised really great points. I think to add to the point about proactively identifying patients who need financial assistance, I think one of the key ways to engender trust and to facilitate those conversations and to allow patients, or to encourage patients to be more open about their financial situation, is to really diversify the workforce as well. I think diversify who are the financial assistance planners, who are the navigators, not just in terms of racial ethnicity makeup, but also, with having diverse languages, diverse cultural competencies. And so I just think that's also a key factor that will help engender trust and open up that conversation.
Perfect. Thank you for that. All right, so we could keep going on about this, and this is a lot of great content, but just one last thing before we open it up for the audience Q&A that I'd love to hear your perspective about. Are there any opportunities for innovation or innovations that you've seen already between health systems and financial services? So this could be things like hospital billing departments, financial navigators, like we've talked about, anything like that. So I'm going to open the floor. Anybody can jump in on this one. But anything you've seen or anything you'd like to see in this intersection between financial health and the healthcare system?
The one example that I can give is in terms of many hospitals and large hospitals in safety net community areas. they tend to have a staff that actually can work with them to get qualified for Medicaid right there on the spot. It's not all hospitals, but many of them do. And that has alleviated patients from leaving the emergency room or not staying for their care. It really has helped quite a bit. So I think that there's a model there in Medicaid that seems to work well, because they also explain the Medicaid program. They will even try and qualify their other family members as well. So I do think there is a model that tends to work well, but I don't know if other health plans would invest the way that Medicaid does in these programs, but it has been exceptional in terms of really getting the that level of integration between the health plan and the provider and the patient.
And I've just seen examples of more with the financial planners. I think we talked about high deductible health plans as we've assumed risk, our own family, financial risk for $2,500, to be able to manage that risk in our whole financial life, our home and homeowners insurance, our car insurance deductibles, our health insurance plan deductibles, that we need to be also very proactive and understand how much risk we are taking on, and how much of a family finance that we need to be able to balance that, and then what other options there are for us, our home equity, our own savings, it's just a retirement or college it's not in college, so our college tuition funds, and so how we all balance that. That I think is really important, and I think we also have to be very proactive. It's us, it's our financial health, and that we have to take ownership. Just like we would ask, what is my treatment plan? I need to be proactive with my financial health as well. So
great. Oh, Sarah, anything to add?
Sure. I just think that I want to just underscore the point of consumer and community partnership, and just the importance of including them in decision making when it comes to not just in issues of, when it comes to like patient experience, but really thinking about like structural issues and issues that can, in other tools like price transparency tools that can really help patients and communities prevent them from medical debt. And so I think, they're often missing in these decision-making tables. And when they are included, it's rarely representative of communities of color and other disadvantaged groups. And so when we talk about models like patient and family advisory councils, we really have to be intentional about how we facilitate and resource those councils in a meaningful way to include voices and priorities of communities of color and others in the policy development and decision-making process writ large. And I think what I mean by meaningful inclusion, I'm talking about well-representation, well-resourced to prevent barriers to participation, and practices that engender trust in the process, including, transparency of decision-making processes, like early inclusion. And these are just the key ingredients to a successful advisory council that can help weigh in on decision-making about price transparency tools or financial assistance programs. And it's a process that can help empower communities and prevent them from medical debt.
Perfect. Yeah, Pat, go ahead.
I've worked with PFACs. I work on helping hospitals create them for many years now. And I do have to say that the issue of reviewing a billing statement or anything like that typically is not done. It's focused, much of it has been focused on the amenities and things like that. We're moving them into now the clinical care, how they can also have their voice heard in the clinical care area. We do ask that they include, and again, this varies by hospitals, We ask them to be inclusive of their community, and the community that doesn't use them, it doesn't participate in the hospital. So I do think there's ways that we can really make an impact and have a greater input into the process through the PFACs. I think that's a wonderful idea to give a PFAC member a bill so that they can analyze it and what does that mean to me, and to make sure there is representation. And I have to say that during the pandemic, I think like some things we took a step backwards in terms of engagement of patients. And, you know, it was almost 2 years. Sometimes the PFACs had a hard time meeting, or they met via Zoom, and some of them couldn't get everyone on board. So I think we've got some rework that we're working on, we're resetting. And I think there's no reason why that the bills cannot be part of it, the discussion on finances and how to have those conversations and be inclusive of people in the community. I know some of the hospitals include patients that don't use their hospital because they want that input as to why this is not a hospital that you want to utilize. So again, I think there's so many ways to spin that and work with it.
Absolutely. And just to dovetail off that too, HFMA, we strongly encourage hospitals to include with their patient financial advisory councils to talk about the finances, and to, Pat, to your point, and Sarah, to also bring on people who are constructive contrarians, who don't, you know, who will constructively tell you about the finance experience, as well as the amenity experience and the clinical experience as well. But I think it's important to make sure that you hear through the patient's own voices what it was like to go through it. And, you know, sometimes it's hard to hear, but it's also a way to make changes. That's really important to do.
Great. Thank you all so much for all of your insights on those. So that is all of the questions that I have, but I'm going to open it up to the audience for some Q&A in these last 7 minutes that we have. Looking through the questions now, it seems like there's a lot in here asking about hospital financial assistance policies, charity care. I guess we addressed some of this, but one of the questions that I see here is, has the charity care provision under the ACA helped reduce medical debt? So maybe we can spend a little bit of time talking a little bit about, you know, just a little bit of like the policy landscape as well. Charity care provision, we've seen a lot of things come out recently about price transparency that you've all mentioned, No Surprises Act. Anything that folks want to add there specifically about charity care provisions and how we're seeing that evolve?
Well, I think initially we did see a decrease in charity, you know, the charity care and bad debt go down. But I think as, you know, the cost of care continued to grow, I think that and more people accessed who are, you know, uninsured and you know, and now we call it underinsured because it's kind of the illusion of coverage. So I think that that's something that, you know, that I think hospitals are monitoring, making sure. But I think that just the classification between bad debt and charity care is kind of a fluid. You know, bad debt tends to be people who can afford it, you know, unwilling but able to pay, and charity care tends to be unable to pay. So, yeah,
absolutely. Go ahead. Anybody?
I think if we were able to get some questions on the patient experience surveys, I think this would really help to drill down the experience of the patients. And I also believe it would, because again, if it's included in the scoring mechanism, it would help to elevate this issue within the healthcare industry.
Right, absolutely. I'm seeing a comment here in the chat, not really a question, but from National Patient Advocate Foundation, we think financial navigation should be fully integrated into the healthcare system as a standard of care. The federal government has a huge role to play. Definitely agree. Any reaction to that, and about, you know, any I guess on the same thread, like, you know, policy things that you would like to see?
I think there's the policy and then there's the practical. The policy will take a while to implement, whereas getting that patient experience question may even go quicker. It could be done now on a voluntary basis. If providers wanted that. I mean, to me, that would be a signal that, either things are working well or I've got some areas for opportunity. I just think there's different ways, but again, the government way seems to take a little bit longer a process. It results in good outcomes typically. So, but I think there's a way a hospital could get it, or a health system can get a good handle on it right now. They don't have to wait.
Yeah.
Absolutely. I think hospitals that are very engaged with their communities can activate that right away. That, sometimes even though federal policy can be very broad, but it still may not meet a specific community's needs. And that still needs to be tailored to that. And I think hospitals and health systems are, geared, are in the right position to be able to do that.
Right. Absolutely. Yeah, definitely agree. The policy landscape, there's so many things that could happen there upstream, as we've mentioned before. But Pat and Rick, I'd love what you just mentioned about, there's things we can do now that hospitals can do now. And that was kind of, where we, that was sort of the idea that we had when we were building our report series about what can actors do now and what the discussion was about today. And I think we've heard a lot of really great strategies that hospital and health systems can take, especially about building trust, between patients and the providing institution and with the clinicians, about taking an equity lens, as Sarah mentioned, including diverse perspectives on these patient family advisory councils, ways to make financial assistance programs and repayment programs more transparent, providing price transparency about the cost of care. Whether people choose to use that information or not, that is up to them, but people want to know ahead of time. And I would encourage everyone who's listening today to see our full report series and the full recommendations we have. There's a lot of really great stuff in there, steps that hospitals can take immediately versus some long-term steps that hospitals can take to improve and prevent medical debt and the burden on their patients. But also we have, recommendations in there for employers and insurers and how actors can sort of take a cross-sector collaboration. So we'll be dropping that link in the chat so you can visit our site there. The last thing I want to do before we close and let you all enjoy the rest of your day is plug our upcoming conference. So the Financial Health Network does an Emerge conference every year on financial health. And this used to be done in person before the pandemic started. We are starting to do it again in person. And we'll be talking about ways that financial institutions and other financial health actors can help support their financially vulnerable patients. So please join us for that. And the link to learn more will be in the Zoom chat as well. Thank you everyone for coming. Thank you, Pat. Thank you, Rick. Thank you, Sarah, for all of your time today, all of your insight. I really enjoyed this discussion. Thank you so much to everybody and hope you all have a nice rest of your day.
Thank you very much.
Thank you, Uzma.
Thank you.
Thank you.